Welcome back to another deep dive.
Glad to be here.
We have a really highly targeted, custom-tailored exploration lined up for you today. It's one that fundamentally reshapes how we understand a very common and, I think, frequently misunderstood medical scenario.
Yeah, misunderstood is definitely the right word for it.
Right. So I want you to just imagine the standard protocol when you go in for a clinical visit. You might be getting a routine chest scan, or maybe your doctor's investigating a persistent cough.
Very common scenario.
Exactly. You're waiting for the results, and the doctor reviews the imaging, and they say that while your lungs are generally clear, they found a pulmonary nodule.
And that is a phrase that instantly changes the temperature in the room.
Oh, completely. Panic sets in immediately.
It really does. Because for most patients, that terminology, it triggers an immediate association with malignancy. It sets off this whole cascade of anxiety.
Yeah, your mind just naturally gravitates toward the absolute worst case scenario.
Exactly. But the question is, should it?
Right. And that immediate translation of nodule to, like, ticking time bomb is exactly what causes so much unnecessary panic, which is precisely why this specific research caught our eye.
It's a game changer.
It is. So our mission today is to unpack this massive, really groundbreaking secondary analysis of the SCAPIS study.
That's the Swedish CardioPulmonary bioImage study.
Right. And this specific analysis was published in the journal Radiology in 2026. It gives us this huge population-level look at just how common these nodules actually are and what causes them.
And we really can't overstate the robustness of this literature. We're looking at the chest CT scans of nearly 30,000 middle-aged individuals.
Across Sweden, yeah.
Right. And by examining a cohort of that size, researchers can finally separate the signal from the noise. They're moving beyond anecdotal clinical findings to establish a definitive statistical baseline for what a normal human lung actually looks like in middle age.
Okay, let's unpack this. Before we get into the more surprising statistics of the SCAPIS analysis, we should probably establish the basics. What exactly is a pulmonary nodule?
So the baseline clinical definition is pretty straightforward. It's a rounded opacity surrounded by lung tissue, and specifically, it measures no larger than 3 centimeters in diameter.
Got it. 3 centimeters is the cutoff.
Right. If it's larger than that, we start using different terminology, like a lung mass. But for nodules, the study categorizes them into distinct types based on their morphology.
Okay, what are the types?
You have solid nodules, which are just what they sound like, dense and opaque. And then you have subsolid nodules.
And those are broken down further, right?
Exactly. Subsolids are split into part solid, which have both dense and hazy regions, and then ground glass nodules.
Ground glass. I always thought that was such an interesting term.
Yeah, it describes how they present on the scan. They look like a hazy area of increased attenuation, but they don't completely obscure the underlying bronchial structures. You can still see through them a bit.
Okay, so why are we suddenly talking about this so much? Why is this a growing problem?
Because we're simply finding them way more often. As our CT scanning technology gets better, higher resolution, more widely used, the rate of incidental findings has just skyrocketed.
Because the cameras are better.
Exactly. A patient comes in for suspected rib trauma, or maybe a cardiac workup, and the scanner catches this tiny 2-millimeter opacity out in the peripheral lung field.
Which they never would have seen 20 years ago.
Never. But now that we see it, this incidental detection initiates a really complex pathway. You're looking at follow-up imaging, sometimes invasive biopsies.
And massive anxiety for the patient.
Huge anxiety.
Yeah.
Not to mention a significant burden on healthcare system resources.
Right. So to really understand what we're looking at, the researchers utilize this incredibly powerful data set. The scale of SCAPIS is just, it's amazing.
It really is.
They used exactly 29,574 participants in the final analysis. Everyone was aged 50 to 64. And they were drawn randomly from the Swedish population registry across 6 different university cities.
And that scale transforms this from just a limited observational study into a highly accurate cross-section of a national population.
But it's not just the size, right? It's the specific population. Sweden itself makes this group really unique for medical research.
Oh, absolutely. Geographically and environmentally, Sweden has a remarkably low incidence of endemic fungal infections.
Like histoplasmosis.
Right, histoplasmosis, which is super common in places like the American Midwest. And those infections frequently leave behind benign nodular scars.
Ah, okay.
Plus, the Swedish population generally experiences lower rates of heavy occupational exposure to industrial particulates compared to a lot of other industrial nations.
So it's a cleaner baseline.
Exactly. It creates a much cleaner baseline for the data.
And looking at the demographics from Table 1 in the study, it's a highly representative group. They're mostly overweight. The average BMI was 26.3.
Which is pretty standard for that age group globally.
Yeah, generally well-educated. Over 45% had a university degree. But the metric that really anchors this whole study, I think, is the smoking history.
That's the really crucial part.
Yeah, a full 51.5% of these participants had never smoked, not even casually.
Never touched a cigarette.
Right. Meanwhile, only 12.9% were current smokers.
And having that control group of over 15,000 never smokers is a massive structural advantage. It allows the researchers to meticulously isolate the variables that contribute to nodulogenesis.
The formation of the nodules.
Right, the formation of these nodules completely independent of the cellular damage caused by tobacco.
So how did they get all this data? The procedure itself was exceptionally thorough. Everyone got a low-dose chest CT scan.
Yeah, about 2 millisieverts of radiation.
Very low dose. And they answered comprehensive questionnaires about their health, their jobs, all of that. And they did lung function tests, too.
Right, advanced spirometry where they blow into the tube.
Exactly. But they didn't just take a baseline breath test. They actually administered a bronchodilator, waited 15 minutes, and then measured the lung's maximum functional capacity to get a true picture of the underlying mechanics. Wow. Okay, so they have all this data, tens of thousands of scans.
And what's fascinating here is the sophisticated approach they took to the imaging analysis. Processing 30,000 scans introduces a huge risk of reader fatigue if you just leave it to human radiologists.
I can imagine. You just go cross-eyed eventually.
Right. Inter-observer variability becomes a real issue. So to counter that, they used highly advanced computer-aided detection software, CAD, as a second reader.
And one thing that really stood out in the methodology was how they measured these nodules using that software. They weren't just looking at the diameter.
No, they utilized the CAD software to calculate the precise three-dimensional volume of the nodules in cubic millimeters.
Rather than just drawing a line across it.
Exactly. And that represents a critical evolution in radiological assessment. If you rely solely on a 2D cross-sectional diameter, think about an elongated flat nodule.
Okay.
Depending on the angle of the CT slice, it might look really wide and falsely get categorized into a higher risk tier.
Just because of the angle it was scanned at.
Exactly. But by calculating the total 3D volume, the clinical team gets a mathematically accurate representation of the actual tissue mass.
Which has to cut down on false alarms.
Drastically.
Yeah.
It's instrumental in tracking growth rates over time, which is the primary indicator of malignancy.
That makes a lot of sense. And that brings us to the big aha moment of the study. The core findings that challenge some very deeply entrenched assumptions.
It really forces a paradigm shift.
Because historically, we all associate lung issues, and specifically nodules, with smoking. But the prevalence data here tells a wild story. Let's look at the numbers for solid nodules based on smoking history.
Let's do it.
In the group of participants who had never smoked in their lives, 32.5% had at least one solid lung nodule.
Nearly 1 in 3.
1 in 3 never smokers. For former smokers, it rose slightly to 34.5%, and for current smokers, it peaked at 37.9%.
When you look at those figures, the proximity of the percentage is just striking. I mean, smoking definitely has an impact. We see that incremental increase up to nearly 38%.
Right.
But that baseline prevalence of 32.5% in lifelong non-smokers is the critical takeaway. It completely flips our understanding.
It proves it's not just a smoker's disease.
Exactly. It shows empirically that pulmonary nodules are just a very common, standard part of normal human anatomy as we age and interact with our environment.
Here's where it gets really interesting. Most of these nodules are tiny. The terminology sounds intimidating, but the data showed that over 27% of all people had solid nodules smaller than 100 cubic millimeters.
Which, to translate that into clinical terms, we're talking about structures less than 5 millimeters in diameter.
So really small.
Very small.
Yeah.
And that size metric is key for reassurance. If you are ever told you have a small nodule, remember this context. Out of the nearly 30,000 individuals scanned, only about 6.1% possessed a concerning incidental nodule.
Meaning one that actually required medical follow-up. So for the vast majority, these are just benign structural variations. But that leaves a huge puzzle. If 32.5% of people who have never touched a cigarette have these solid nodules, where are they coming from?
Right. If not smoking, then what?
Exactly.
To figure that out, the researchers dove into the data using a statistical tool called robust Poisson regression.
Which is a very rigorous way to find the prevalence ratios, right?
Spot on. They use Poisson regression instead of standard logistic regression because when a condition is as common as 30%, logistic regression can artificially inflate the perceived risk.
It makes it look scarier than it is.
Right. By using robust Poisson, they calculated true prevalence ratios, meticulously adjusting for things like age, sex, and testing sites.
And what did they find for the never smokers?
The real culprits were underlying lung conditions. Specifically, they found a huge correlation with something called reticulation.
Reticulation, what does that look like?
On a CT scan, it appears as a fine net-like pattern. It indicates interstitial thickening or minor lung scarring, usually from old, resolved infections.
Like a footprint of a past cold or something.
Exactly. Having reticulation more than double the prevalence ratio is a PR of 2.28 for having a larger solid nodule, meaning 1 over 100 cubic millimeters.
Wow. More than doubled.
They also found a strong link with bronchiectasis, which is a condition where the airways are permanently widened.
Which makes it harder to clear out mucus and debris, right?
Exactly. When those airways lose their ability to clear inhaled debris, it leads to recurrent low-grade local infections.
And that causes scarring.
Right. The nodule we see on the scan is essentially just the fibrotic scar tissue left behind after the immune system has done its job managing that local inflammation.
That makes total sense. And it wasn't just internal biology either. The occupational questionnaires brought in some major environmental hazards, too.
Yeah, the workplace data was very telling.
People who were exposed to vapor, gas, dust, or fumes at work also showed significantly higher rates of nodules.
It highlights how long-term environmental inhalation slowly alters your pulmonary landscape over time.
But obviously, for current smokers, the risk factors compound.
So heavily. When you combine active smoking with structural degradation like emphysema or COPD, the prevalence of the largest nodules, those over 300 cubic millimeters or about 9 millimeters in diameter, it accelerates dramatically.
The cellular damage from the smoke just acts as a multiplier.
Exactly.
Now, while the inflammation and environmental exposure data makes perfect sense, there were a few quirks in this study, some real contradictions that seem counterintuitive at first glance.
Yeah, the data always has a few surprises.
The biggest anomaly for me was regarding obesity. The source material showed that obesity actually seemed to have a protective effect against subsolid and ground glass nodules.
It looks that way on paper, yeah.
The prevalence ratios dropped significantly, like 0.44 for part solid nodules. It sounds like being obese actively prevents these nodules from forming.
If we connect this to the bigger picture, we have to look at the technology, not just the biology.
Okay, what do you mean?
Obesity isn't actually protecting the lungs. This finding has everything to do with X-ray attenuation.
Right.
Remember, the protocol used low-dose CT scans to prioritize patient safety.
Right.
Ground glass nodules are faint and hazy. When a low-dose X-ray beam passes through a larger volume of chest wall tissue, the extra body tissue simply scatters the X-rays.
It creates image noise.
Exactly. You get photon starvation. The scanner, and even the advanced CAD software, just can't resolve the subtle density differences needed to see a ground glass opacity through the extra tissue.
So it's not a medical miracle, it's a technological limitation. The nodules are probably still there, the scanner just can't see them.
Precisely. They're camouflaged.
That is fascinating. It really shows why you have to look deeper than just the raw numbers. There's another mind-bending paradox here, too, the multiple nodule paradox.
This is a really important one for clinical practice.
Yeah, intuitively, if a doctor tells you they found 1 nodule, that's bad. But if they say they found 5 nodules, you'd think that's 5 times worse.
It seems like simple arithmetic.
But the study highlights that finding multiple small nodules is actually less concerning than finding just 1 isolated nodule.
Right. In pulmonary radiology, discovering numerous widely distributed small nodules usually points to a benign systemic process.
The source discusses this by citing findings from the Pankin study and the Nelson trial, right?
Yes, those massive screening protocols revolutionized how we handle this. They proved that scattered, multiple findings are typically just the calcified scars from old minor infections.
Like previous bouts of pneumonia or generalized inflammation?
Exactly. They are inactive artifacts of an immune response that has already finished.
But a single nodule.
Right, a solitary, distinct nodule, especially one that shows rapid growth over time. This is the one that raises red flags for malignancy. A solitary mass is operating on its own biological agenda, completely independent of the surrounding tissue.
So what does this all mean? We've talked about cubic millimeters, Poisson regressions, ground glass opacities. But why should you, the listener, sitting at home or commuting right now, care about the lung scans of 30,000 Swedes?
Because we live in an era of hyperinformation and hypermedicalization.
We know too much about our own body sometimes.
We really do. As technology gets better, we are going to find more abnormalities inside ourselves. We're finding what we call incidentalomas, asymptomatic things discovered purely by chance.
And without the right context, every incidentaloma feels like a crisis.
Exactly. This study is a crucial tool because it refines our risk models. Knowing that 1 in 3 perfectly healthy non-smokers has a lung nodule changes the baseline of what normal is.
It redefines normal.
It does.
Yeah.
It empowers doctors to say, look, this small nodule is just a standard anatomical variation. It prevents unnecessary invasive biopsies, it saves healthcare costs, and most importantly, it saves patients from weeks of agonizing anxiety.
It stops you from living in diagnostic limbo, worrying if a tiny scar is actually a malignant threat.
Exactly.
So, to summarize the key takeaways for everyone listening, pulmonary nodules are incredibly common. Smoking isn't the only trigger environmental factors, and minor lung scarring play huge roles.
Huge roles.
And finding a tiny spot on a scan is usually just a footprint of a life lived, not a ticking time bomb.
Well said. And this raises an important question to mull over.
Oh.
As our imaging technology eventually reaches a microscopic level, will there even be such a thing as a perfectly normal scan anymore?
That's a scary thought.
Or will we have to completely redefine human health, not as the absence of anomalies, but as the ability to peacefully coexist with them?
Wow. That is an incredible point to end on. As technology gets better, we're going to have to get better at understanding what it's showing us. Thank you so much for joining us for this deep dive into the SCAPIS study. To everyone listening, keep questioning the world around you, keep looking past the surface, and we will catch you next time.